And before we get going, just so everybody knows, if you have any questions that arise during the course of the presentation, please feel free to use the chat function and we'll address those at the end. We are 1 minute past 11, so I think we'll go ahead and get started here. I really appreciate everybody taking time out of their busy schedule to join us for the Tria Health webinar series. Today's topic is why everybody should be talking about pharmacist interventions, how pharmacists close health gaps in members with chronic conditions. My name is Jason Grace. I'm the Vice President of Clinical Services here at Tria Health. So I oversee all of the clinical staff and the clinical programming. I've been a pharmacist for 20 years, over 20 years, and I've been at Tria Health now for almost 10 years, which, boy, when I say that out loud, it makes me feel old, but I'm going to go with experience for the purpose of today. So pleasure being with everybody today. A little bit of background, Tria Health is a comprehensive chronic condition management company. We were founded in 2009. We're independently owned. And I feel like we are uniquely positioned in the chronic condition space in that we are a pharmacist-led company, meaning we utilize clinical pharmacists for all of our patient care services. So our clinical staff is tasked with, whenever patients engage with Tria Health, we do a comprehensive and thorough A to Z review of all medications and all conditions. And really try to identify what are the reasons that patients are not meeting their health goals, and coming up with individualized solutions to close those barriers and gaps. Our patients are supported through telephonic consultations, extensive disease and health education. We design an individualized care plan after each and every consultation. And included with communication to the patient on those recommendations and interventions, it's a high priority for Tria to coordinate with their other healthcare providers to give transparency and visibility in terms of what we identified during those consults so that their providers and physicians can take action on that. We also support patients through digital support tools. This includes the Tria Health patient portal, the Tria Health app, as well as our cellular remote monitoring devices, which includes a blood glucose meter and a blood pressure cuff as well. The data that we're going to look at here later today really revolves around gaps in care. And a gap in care is defined as if when patients fail to achieve either their treatment goals, so we're talking about A1C goals, blood pressure goals, et cetera, or lack of adherence to preventative care guidelines or evidence-based treatment. So annual retinal eye exams for your diabetes patients, statin therapy for those that are high-risk members, steroid inhaler use for uncontrolled asthma patients. And these are really the key metrics that are reviewed and assessed during consultations. And for the past 7 years, Tria has integrated into our proprietary software system all of these metrics at the condition level that allows us to make those assessments and, more importantly, identify, report, and track changes at the patient level. And so these key clinical metrics and these gaps in care are what we're going to look at from a population-based perspective here in just a few minutes. Now, stepping back a minute and just asking, is open care gaps a problem, basically, or how is the healthcare industry doing, and is there an impactable population whenever you look at it at a condition level? And if you look at NCQA data, it certainly supports the fact that there's room for improvement. There's impact that can be made at a population level, as NCQA data would suggest that 40% of diabetes patients are not at their goal blood pressure. Over 60% aren't at their goal hemoglobin A1C. half of them haven't had a retinal eye exam in the last 12 months. And it's really a combination of these factors that lead to poor control of chronic condition and lead to those negative outcomes and complications associated with chronic condition that lead to serious events, that lead to heart attacks and strokes and development of kidney disease. And it's usually not necessarily one, but it's a combination of these factors that lead to poor control and lead to the negative outcomes that we're really trying to prevent in these common chronic conditions, such as diabetes, such as high blood pressure. Now, there's a variety of reasons why these care gaps exist. And certainly one of the main drivers is non-optimized medication use. Different studies have suggested 50% or more patients do not take their medications as prescribed. Often when we talk about medication use, adherence is the primary metric that is placed with medication use. And while adherence is absolutely crucial and critical, if the patient is prescribed the right medication for their particular condition, taking it consistently is necessary to achieve the desired outcome. But in addition to adherence, if you talk about what does non-optimized look like, it's also what are the other factors involved in not achieving ideal medication regimen for chronic conditions. So it's not only adherence, it's also if they're on a 3 or 4 drug regimen for diabetes, is the combination of those particular treatments appropriate for the patient, maximizing efficacy and limiting the potential for side effects and problems. So sometimes it's maybe the patient is adherent with the regimen, but they aren't on the right medication. And it's really the right medication at the right dose for the right patient. Sometimes there's dosing issues, whether it be too high or too low. Sometimes we're dealing with polypharmacy. And so we have situations where patients are on medications that are no longer clinically indicated, or maybe no longer clinically necessary due to improvement in their disease control. And these are the types of issues and problems that come up consistently that, again, pharmacists are well positioned to identify and come up with solutions for these. Now, we know that non-optimized medication therapy costs a lot of money, leads to bad outcomes. And so what are some solutions to improve medication optimization and close clinical care gaps? So really, there's a variety of things that have been shown to be effective in terms of improvement in chronic conditions. And there's really 3 factors: patient-centered chronic condition management. Telemedicine has proven to effectively reduce clinical care gaps and improve control of chronic conditions. And then pharmacist involvement. And so really those are 3 areas or categories that Tria attempts to maximize those by using pharmacists, by using telehealth, and by using patient-centered chronic condition management. A lot of the published studies that have to do with pharmacist involvement in condition management and improving outcomes, there's a whole host of published studies regarding this. And most of these studies have focused on single disease states. So pharmacists improving outcomes in hypertension, or in diabetes, or in anticoagulation. And the numerous support that integrating clinical pharmacists into the care model for that patient can improve outcomes. What we attempted to do in terms of our evaluation was, like I said, for the past 7 years, we have a large patient population, and we have a treasure trove of data from all of these metrics and assessments that we have been documenting and reporting for during that time. So we wanted to take a bit of a broader approach. And what we did was to gauge the impact and significance of pharmacist interventions on clinical care gaps in patients with chronic health conditions via phone consultation. So this was an evaluation that we completed last year. It was a retrospective pre-post study with paired data. And what we attempted to analyze was looking at patients who engage in Tria Health and what their health status and what their gaps in care looked like upon entry into the Tria Health program. And then we tracked those patients over the course of time to see what the movement or the impacts look like on their care gaps. We included patients who had had 3 or more telephonic consultations with us. So patients that we have had the opportunity to have multiple consults with and show and drive impact on. We looked at this over a 5-year period. So we really wanted to go broad, look over a long period of time in an effort to get the highest number of analyzable patients that we could look at. And we also wanted to look at more than just a single condition. So we looked at 7 chronic conditions that we'll look at on the next slide. And really, we were looking at, again, that movement from did care gaps close over the course of time with Tria Health? And also, to be fair, did they move the opposite direction, or did they open over the course of time? So what we ended up with was a large sample size. So these were the chronic conditions that we analyzed: hypertension, high cholesterol, coronary artery disease, asthma, COPD, and diabetes. Preventative measures in and of itself is not a chronic condition, but it is the category that we use internally for assessing age and gender specific cancer screenings and vaccination requirements. And so all patients have some level of preventative care that is appropriate for them, whether it's as simple as an annual flu shot up to colon cancer screening or a lung cancer screening. And so all that is captured under preventative measures. And so we ended up with, if you look at it at a condition level, anywhere from as low as 162 patients for COPD and as high as over 7,600 patients for preventative measures. A large population in diabetes with over 5,200. In general, these were older patients who were very complicated and complex in terms of the number of medications that they were taking and the average number of chronic conditions, total chronic conditions that they had. So ended up with a lot of patients and a relatively complex patient population. So with the results of that, what we found was, do we see an opportunity, an impactable opportunity upon entry into the Tria Health program? And if you look at the chart here, if we start with hypertension, what the bars represent is the number of patients, the number of assessments, and the number of open care gaps whenever they presented to Tria Health. And we saw pretty consistently across the board for these 7 conditions, there was a lot of opportunity for closure for people who had open care gaps, not meeting their treatment goals, not up to date on their preventative measures, or not on evidence-based and guideline recommended treatments. There was ample opportunity for improving those particular metrics at the patient level. And then in terms of closure of those open care gaps, again, looking over a 5-year period for patients who had 3 or more consultations, we saw a very positive trend in terms of the number or percentage of care gaps that were open that as of their last consultation were closed. Close to 50% or higher for all 7 analyzed chronic conditions. Now, the real analysis that was done with that was, as I stated earlier, looking at the movement in both directions. So not only percentage of care gaps that were closed, we also looked at it in the other direction, and that's where we used the McNamara test to see if there was a statistically significant difference in terms of movement in a positive direction, essentially. And again, if you look at that, we had a large percentage of open care gaps that were closed during their management by Tria Health. and a very small percentage of care gaps that moved in the opposite direction. So we feel like this supports the previously published studies and articles that have suggested that integrating clinical pharmacists into the care plan and into chronic condition management can help improve outcomes. So the take home from this is consistent with what NCQA data shows, is that open care gaps persist despite standard of care. And that combination of patient-centered chronic condition management, utilization of telehealth and telemedicine, and clinical pharmacists can help improve those metrics, drive patients to better control of their chronic conditions, and ultimately avoid those consequences and complications associated with uncontrolled chronic conditions. We saw significant change across all 7 of the conditions that we analyzed, and feel like that telemedicine and pharmacists is a good solution in play for populations that are struggling with control of chronic conditions. And with that, I will conclude the presentation portion of this. We do have a handful of questions that have already come in, and so I'm going to address those, and then we'll see if we have additional time for those. One had to do with how can the pharmacist ideally assist in improving adherence? And boy, it really comes down to from my perspective, it comes down to identifying the core reason that non-adherence is occurring. And oftentimes we think adherence along the lines of, well, the patient just doesn't like to take their medication or they forget to take it. In my experience, that's actually the easier situation. If it's simply they're willing to take it, they're able to take it, they simply forget because they're taking it in the evening or something along those lines. With adherence, it's really what is the root cause of them not taking the medication, and oftentimes forgetfulness is not it. It has to do with health literacy issues in terms of understanding the benefit associated with that treatment. It has to do with cost barriers that prevent them from filling it on a regular basis. And so exploring their plan design and the savings opportunity associated, if necessary, for those medications. And so it really comes down to just identifying with that patient for that particular treatment, what is the real reason that they're not taking it, and coming up with solutions. Sometimes that can be as simple as a pill box, so they remember to take it consistently. Or it could be their lack of understanding in terms of why I should be taking this. It's a very common scenario we run into with inhaler use for respiratory disease. Patients taking maintenance inhalers or steroid inhalers that really prevent symptoms from occurring, reduce the risk of exacerbation, yet they don't necessarily feel better whenever they use it immediately, or they don't breathe better immediately. So then they just stop using it, thinking like, well, my breathing isn't improved within 5 minutes after taking this medication. So then they stop using it. So that's more of a education and knowledge and health literacy issue that needs to be corrected during those consultations. We also had a question of how do we empower patients and employees to ask the right questions of their physician and or pharmacist when receiving and filling a script. And boy, this is a big piece of what we do. We call our chronic condition management program the PA program, so the Pharmacy Advocate Program. And we are always attempting to advocate for the patient, but also teach the patient how to advocate for themselves, how to ask the right questions, how to get clarity from their providers. If there are instances where the patient doesn't even know why they're taking a medication, and maybe it isn't clear or obvious from our evaluation, it's teeing them up with the proper understanding and insight and the right questions to ask is, what is the core benefit associated with me taking this medication, and kind of forcing their providers to answer those questions for them. It's not uncommon that patients see their physicians, they get prescribed treatment, they just start taking it. There aren't a lot of questions asked at time of initiation. And then we get 6, 9, 12 months down the line, and the patient's not even sure that the benefit or the purpose of said treatment. And so those are conversations that are had on a daily basis within our patient population. There was also a question about biosimilar. Probably, maybe it wasn't a full question, but just biosimilar interventions. I would say from Tria's perspective, we certainly understand the potential use and benefit of biosimilar agents, especially when you're talking about in not only the diabetes space, but the specialty space. And we are always going to be aligning under plan decisions that have been made, formulary decisions that have been made, and we certainly would advocate for change for a patient if it benefited the patient from a cost perspective, if it benefited the plan, and if it was clinically appropriate and allowable under the kind of the formulary guidance. Okay, one more here. Could you elaborate on how you define number of care gap assessments per condition do you mean by a Tria Health pharmacist? Good question. So on one of the slides we presented earlier, it showed the number of assessments at the condition level, ranging from 4 all the way up to 12 or 16. Those are standardized metrics that we have built into the software. For example, for diabetes, there's a comprehensive diabetes management encompasses a number of different things. It includes A1C control, blood pressure control, cholesterol, preventative screening such as eye, feet, dental, screening for kidney disease. If the patient is experiencing recurrent hypoglycemia, all of those metrics and assessments are done during every consultation with Tria Health. And those are those don't vary from patient to patient. The assessments and the care gaps that we are assessing are consistent across the board for all of our pharmacists. All right, I think that's it. I really appreciate everybody taking time this morning. And don't hesitate to reach out to Tria or any of your contacts if you have any additional questions.